All right, welcome back. All right, so now this is going to be part one of the epidemiology lecture. Oops. Okay, we are really switching gears here from behavior change to epidemiology. You all, because of this pandemic, you have had the privilege of having been introduced to what epidemiologists do. In previous semesters, before the pandemic, a lot of times students had never even heard of the field of epidemiology. And I teach it in this class because I want you to have an appreciation for this scientific field of study. Also know that there's an epidemiology class that they offer over in the public health department. But epidemiologists feed all these other health professions good scientific data. Okay, and so they feed us nice science, and it helps inform a lot of things. So I'm going to define epidemiology here in a bit, but let me tell you the story of Semmelweis. So Semmelweis, back in history in Vienna, keep in mind that this was a time in history, and I'm not going to expect you to remember dates because I'm terrible with history and I'm terrible with dates, was at a time where it became the thing for women who were going to birth a baby to start to go to hospitals to birth babies, because hospitals were considered safer than having home births. Okay. And Semmelweis, let me go ahead and go to the next study. He was the owner of a hospital in Vienna, and he had a problem in his hospital. Now, keep in mind, I'm going to go back. Let me talk a little bit about these miasmas. The scientific belief at the time was that disease was caused by miasmas, which were kind of like vapors or fogs, and miasmas would kind of roll into a town, and people would breathe these miasmas and they would get sick. So it was basically an idea that the weather caused disease. And nowadays, particularly after the microscope was invented, we realize, okay, there's a lot of other things that cause diseases. It's not the weather. But we do have in common language nowadays, and for those of you who have survived Boone, where it's like, snowing one day and then it's 70 degrees the next day, and then it's sleeting the next day, and then it's like, warm again, you can put your shorts on the following day, and then you get sick and you're like, well, no wonder, look at this crazy weather we've been having. So it still kind of remains in common language nowadays, this idea of the miasmas, even though we know that causes of disease, like that was like a pretty silly way of thinking about it back then. Okay. So he's been written about, Semmelweis was written about by Oliver Wendell Holmes. Let me go back there. And in his maternity ward, he had a problem. He had quite a few women who were coming to this hospital to birth their baby safely in the hospital, but there was this thing called puerperal fever, which simplified was called childbirth fever. So these women, they would birth their baby, and then they would start complaining of excruciating abdominal pain, spike a very high fever, seizure, and die. Okay. So Semmelweis has a problem. He's got these women coming to his hospital because it's supposed to be safer to birth babies there. Babies are fine, but mamas are dropping like flies. Mamas are dying. Okay. And he starts to observe what's going on. He starts to think about scientific thinking and observe what's going on. He's got two different types of people that are delivering babies. And you all have heard me say this already, that I think it's silly to talk about, oh, I'm going to save this file that's burning. Let me save it. Let me just kind of make it real small because it's right in my way. You all can't see it, but I can see it. Okay, so that previous class just burned. He's got two types of people that are delivering babies, and like I said, it's really the mom that does the work. You got the midwife or the OBGYN or the med student kind of catching the baby and cutting the cord, that kind of thing. And he starts to collect data on the number of women who get sick and die who are delivered by midwives and medical students. And if you saw this data here, how many of you, just show of hands, would want the medical students delivering your baby? Okay, some of you. How many of you would say midwives? Show of hands. Okay. The answer is there's no correct answer here because there's very important information that we don't know. What we've got here are raw numbers. So what's missing? Somebody speak up and tell me what's missing.
How many babies were actually delivered overall?
Yes. Per med student, per midwife. Yes. Thank you, Carson. Yeah. Now, we could assume it's 50-50, but we shouldn't be assuming that. And in this situation, what they actually found, if you took these numbers, that very few women were dying after a midwife delivered a baby. Lots of women were dying after the med students delivered a baby. So Simon, after he collects this data, he realizes something dangerous is going on with these med students, and there's something safe going on with these midwives. So he goes and observes their deliveries. And he really, I mean, he can't tell a difference. It's like they're doing the same kinds of things. They're touching the women in the same way. They're cutting the cord in the same way. Maybe they're giving stitches in the same way. There's absolutely no difference. But there was a gender difference. All of the med students at this point in time were all male. All of the midwives at this point in time, they were all female. But when he watched them behaviorally, they weren't doing anything different in the deliveries. So he can't figure out what's going on until he realizes they do different things in between deliveries. Okay. The midwives, all women, they go into like the kitchen and they make food and tea and they play cards and they knit and they gossip and they just hang out with one another and enjoy each other's company in between deliveries. The med students, on the other hand, they're either reading books or they would go down to the basement of the hospital where the cadaver lab was. Keep in mind, this is before formaldehyde. I can still smell, I still have a smell memory of formaldehyde. I can still smell it in my head when I think about it. This is before formaldehyde or any other types of preservatives. And they would go down in the cadaver lab and they'd take their scalpels with the professors down there and they would dissect human cadavers that were rotting. Got it? Now, one of these med students is particularly clumsy and accidentally takes his scalpel and cuts the finger of the professor who's in there showing him how to dissect that cadaver. And lo and behold, we have this male professor who has the first case of childbirth fever. Very quickly starts complaining of horrendous abdominal pain, spikes a huge high fever, has a seizure, and dies. So what's going on here, folks? What's causing this childbirth fever?
Infectious disease.
You got it. Yeah. They're touching rotten cadavers and then they're going and they're exchanging with woman's blood as they're delivering babies, giving her this infection. This was before hand washing. This was before the microscope. Yeah. So Simoes like takes this scientific, this mathematical data and what he has observed. And he's like, I don't know what's going on, but something is happening with their hands. And he writes a research paper about this. And he gets everybody in the hospital before they go into the delivery room to wash their hands in this like chlorine and lime solution. And he reduces the number of women that are dying, and more women are going home with their babies after doing this. But his scientific paper was met with outrage. Absolute outrage. And he was fired from his leadership in the Vienna hospital. His career was ruined. Nobody believed the scientific paper that he had written. And it wasn't until they developed the microscope that he was given validity to what he had found in this like naturalistic experiment that was going on in his own hospital system. And so Simoes is now considered to be the founder. He founded the field of epidemiology, okay? Because he was the first to collect data to use logical math to solve a healthcare problem, okay? And that's what epidemiologists do. So you've always got to control for the time period between two groups. So like you would not measure, say, the med students for a month and the midwives for a whole year. You've got to absolutely know, this is exactly what you said, what is the population that's on the denominator? And we only can compare rates. We cannot compare raw numbers. I get frustrated every now and then when somebody in the media will post information in the media that is raw numbers. So like, let's say you heard, and there's protests going on right now. Let's say you heard more police officers were killed in Chicago than killed in Boone. Would you go, so what? Yeah, I mean, think of how many, I don't know how many are in Chicago, but there are a lot of police officers in Chicago, and there's like, I don't know, a handful of nice police officers in Boone, that type of thing. Yeah, that comparison would not make any sense whatsoever, okay? So we've got to use the rates. We've got to know who's vulnerable on the denominator. And then keep in mind, it really does have to be somebody vulnerable on the denominator. So if we were looking at, say, prostate cancer, and we had cases of prostate cancer, who would we have on the denominator and who shouldn't we have? Men, fair game? Women, fair game? No. Yeah, we don't have prostates. Yeah. Yeah, so, and it'd be the same kind of thing if we were looking at, say, ovarian cancer. We would only include women. We would not include men with that. Okay, so let's define epidemiology. So epi means upon, demos means people, logos means logic or the study of. So epidemiology is the study of that which befalls people. And that which befalls people, we've only got a handful of categories here. Disease, psychological disorders, injury, okay? All the bad stuff that can happen to the human race, okay? That which befalls people. And the assumptions here is that this stuff doesn't befall us randomly. You guys in this class, you pay more for your car insurance than you gals in this class pay for basic car insurance, assuming you haven't been in any accidents. Why do you guys have to pay more for your car insurance than the gals do?
Because we like to drive fast.
Drive fast, engage in more risky behavior, and just the data suggests you all get into more accidents. You bang up more cars and create more damage to cars than gals do. Okay, so it's not sexist discrimination. It's based on the actuarial data. And that's why car insurance companies can legally get away with charging guys more. Got it? Okay. So these things don't befall people randomly. Now, sometimes there's some randomness to the world, but there are patterns, and it's the epidemiologists that they get in there with the math, the data collection, the math, and the epidemiologists solve these puzzles. Okay. And again, we've been hearing a lot about what epidemiologists know about this pandemic and the things that they are recommending to us based on their data. So they are informing us in very valuable ways right now, but epidemiologists have been informing healthcare for a long time. So now let's take the uses of epidemiology. Why do I want you to have an appreciation for this field, even if you don't go on and take an epidemiology class? First of all, they identify causes of disease. So Seymour Weiss was a beautiful example of him taking data, doing the math, making scientific observation, trying to track down what was going on and what was killing these women in his hospital. So identifying causes. Epidemiology is population-based data. So they're really good at doing representative sampling or weighted sampling. And this helps complete the clinical picture. So let's say we were an ER doc back in the 70s. And a lot of people were out there using hallucinogens in the 70s. And don't go home and tell your mama that I'm saying hallucinogens are great and they're not dangerous, because that's not what I'm saying. But if you were ER doctors working in the 70s and people were brought to you who were having really bad tripping cases after dropping a hallucinogen, and they were psychotic and they were scared and they were thinking the devil's after them or they're possessed or that kind of thing, you would make a conclusion, wow, hallucinogens are very dangerous for human beings. However, if you are not an ER doctor that, I don't know, was at a PCP party or something like that, there might be a lot of people at that party having a great time dropping a hallucinogen or dropping acid and just having a fun trip of it all. Okay. Now, again, I'm not saying hallucinogens are good nor bad. I'm just saying, if you only looked at the ER seeking patients, you would get this idea that, whoa, bad trips happen a lot. If you started to survey individuals who had used these things population-wise, you would get a very different picture. Got it? Okay. Next thing that epidemiology does for us is it helps us with the classification system. So for psychological disorders, we use the DSM-5, and we classify psychological disorders based on shared symptoms. So anxiety disorders, they all have anxiety. Mood disorders, they always have issues with mood. Psychoses, schizophrenia would be the psychotic disorders, that type of thing. Eating disorders always involve eating behavior, problematic eating behavior, that kind of thing. So we use the DSM for psychological disorders. We can also use the ICD-10. The ICD-10 is International Classification of Disease, and we're on the 10th version. And this classifies medical disease and injury into particular categories. So like we know coronavirus is a virus, and viruses are classified all together with different kinds of viruses and the types of viruses. Bacteria are classified under the bacterial stuff. Protozoa are classified under protozoa infections, that type of thing, fungal, et cetera, et cetera. Does that make some sense? So it allows us a classification system. And then healthcare providers, they have to create diagnostic codes for their patients. What are they treating diagnostically? And they use these ICD-10 codes. And then they have procedural codes, which would be whatever treatment or procedure that they are using for that particular patient. So this actually unifies our healthcare system. It unifies the insurance companies. It allows scientists to talk with one another because we have particular names and codes for different types of diseases or injuries or psychological disorders. So epidemiology also allows us to determine effectiveness of prevention. So as an example, when we were on shelter at home in place before phase 2 in North Carolina, when we were on phase 1, we started to see a drop in new cases, and we flattened the curve. We kept people out of the hospital system. But in phase 2, when we started opening back up, what has happened, you all? What has happened in North Carolina?
The cases went back up.
Yeah. Yeah. So this is a good example of, we look at what was the public health policy and what were the rates of new cases versus when we opened up and we changed public policy. Now we're seeing more people contracting. And actually we were one of the highest this past week, one of the highest states in increase in number of new cases. So epidemiology allows us to sort of track prevention. It also allows us to track treatment interventions. Whenever we get a vaccine on the scene, it's going to be really interesting to see what happens in tracking after individuals have an opportunity to be vaccinated. Although I know there's a lot of people out there anti-vaxxing and saying, even if we get a vaccine, they're not going to do it. I'll be the first in line. All right. Other means of uses, a way of monitoring a community, a region, a nation. And I'll give you an example here. I used to work closely with a local pediatrician before he passed away, and he would send me clients, and my kids saw him when they were little. And when he first came to Boone and started practicing pediatrics in Boone, he thought he was seeing a lot more cases of kids coming into his peds office with asthma. So he started working, this is Dr. Bill Horn, he started working with the local health department, and they started collecting data on what's going on up here in the high country. And you would think, we're up here in the high country, we've got all this fresh air, we've got all this nature, that cases of allergy and asthma would be very low. But what they actually found when the health department started collecting data is our cases of asthma and childhood asthma here in the high country are much higher than the Piedmont and the regions surrounding us, Charlotte, Winston-Salem, Tennessee, that type of thing. And they started exploring what was going on here, and there were a couple of things that they realized were happening in the high country. Lots of, I've known a lot of people who move here and have never had allergies like they have once they moved to Boone. We've got all this plant life, and that for a lot of individuals, if you're allergic to plants, we've got that. We've got acid rain. If you go like up to Beach Mountain and you look at the trees up there, you can tell that the trees have been damaged from acid rain. So one of the ways of thinking about it is pollution from the lower lying regions rise up, that pollution rises up to the high country and it's more concentrated here. We've got Christmas tree farming and pesticide use on a lot of the Christmas tree farms and other farms around here. And then this is like sacrilegious, but we've got Tweetsie Railroad. My kids loved Tweetsie when they were little. But if you've ever been to Tweetsie Railroad, that train is spewing out coal ash all day long. And that is adding to the pollution in our environment. So as this was studied in the region, it made some sense. Yeah, indeed, we do have more asthma. And now we've got primary care doctors and pediatricians that are doing a better job of screening for asthma in kids. Okay, make some sense? Okay, epidemiology helps us identify high-risk groups. So I got a picture of a quarterback here. They are high risk for getting smushed in football matches. And there are reasons why their helmets are built the way they are. There are reasons why there are different rules that go down in sports of football of how you're allowed to hit, how you're not allowed to grab face masks, all that kind of stuff to try to prevent injury in people who play in those high-risk conditions. And there are lots of other groups. You can think of lots of other groups, but identifying people who are at higher risk and then trying to create preventative measures and means of protection for individuals who are particularly high risk in different populations. Epidemiologists help us study trends over time and make predictions over time. And I'll give you an example of this. Before we had chickenpox vaccine and measles vaccine, you would see this trend that every 4 or 5 years, there would be a measles outbreak or a chickenpox outbreak. And the reason for that was there was a South Park episode where all the moms were trying to get all the kids chickenpox at the same time. So they had one of the little kids who was infected and all rashy, would go to the other little boys' houses and greet the kid at the door, and then they would spit in their mouth, which is great. It's really gross. But they were deliberately trying to give all their friends chickenpox because the moms wanted them to all have it all at once, because after they had it, they'd be immune. So why do you think it would be like an every 5-year trend? And epidemiologists could predict it.
Because all these kids get it at one time, and then, they grow older, they're immune to it, and then the next group of kids come along and they're not.
You got it. So it was very infectious. It would spread through daycares. It would spread through elementary schools. Everybody would get it. Everybody would form immunity. There's no new people to get it till you got a fresh batch of kids coming into the daycares and the elementary schools. You got it. Yeah. So by studying those kind of cyclical things over time, the epidemiologists were able to make predictions. And then now most kids get measles and chickenpox vaccines. Okay. Some basic statistics here in epidemiology. Prevalence would be the number of cases that are diagnosable at a given time relative to the vulnerable population. So we could look at weekly prevalence, monthly prevalence, yearly prevalence of confirmed cases of coronavirus in North Carolina, as an example. Incidence, on the other hand, is the number of newly diagnosed cases over a particular time period over a vulnerable population. So incidence could be something like new diagnosed cases of coronavirus in the past week. Prevalence would be all of the diagnosed cases of coronavirus in North Carolina since this thing got started. Morbidity is the number of people who have a diagnosable illness over the vulnerable population. So morbidity could be those with diagnosed coronavirus over the total population. Mortality is death. So mortality would be the number of cases of death from coronavirus, usually over the vulnerable population. Oftentimes it would be over those who were diagnosed with the virus. Sometimes it's mortality of number of deaths over the entire population. So there's different ways of kind of calculating mortality. So prevalence, existing cases over denominator, incidence, number of new cases over denominator, morbidity, it would be illness or psychological disorders or injury over vulnerable. Mortality would be death rate. Any questions here?
Could you go over the difference between morbidity and incidence one more time?
Okay. And keep in mind, Daniel, a lot of these are going to overlap depending on whatever we're talking about. It could be the same statistic overlapping a bit, but incidence would be only taking the number of newly diagnosed cases. So let me do breast cancer as an example. So breast cancer would be all of the people who've had breast cancer over the population. But if we wanted to look at number of newly diagnosed cases, maybe from mammography in the last month of breast cancer, we would just look at newly diagnosed cases in the last month. So from a Venn diagram standpoint, incidence is going to be within prevalence, but prevalence is going to be outside of incidence. Other questions? Okay. Okay, let's talk about relative risk ratio. And I'm going to walk you through this. Actually, what I think I want to do is, do I want to pull up a whiteboard? I think I do. Let me stop share here. Okay, I'm going to use it as an example lung cancer. And I'm going to, what I'm going to come up with here is a relative risk ratio. And up here on my top numerator, I'm going to do number. Let's do lung cancer. So this would be a morbidity. This would be a diagnosis, not death. We're talking about morbidity. And here I would have smokers. This is horrible. Okay, smokers. That says smokers, everybody. Okay. And I would put this over a denominator of smokers. So we got people with lung cancer who are smokers. That's okay. You got it. All right. In there, you know what it says. And then down here, I'm going to look at number of lung cancer cases and what? Out of who? Your mouth, I can see your mouth in it, Carson. Non-smokers. Yeah, non-smokers. And then this is going to be a rate over the nons. Got it? So number of cases of lung cancer smokers out of all smokers. We're going to stack that baby over number of cases of lung cancer non-smokers over the non-smokers. That is going to give us a ratio. And in this particular case, that ratio is 10.0. Huge for a relative risk ratio. 10, that's a dot, that's a dot. 10.0, which means chances of getting lung cancer if you are a smoker, 10 times that compared to if you're a non-smoker. Any questions about this before I go back to the PowerPoint? So 10 times more risk of getting lung cancer as a smoker compared to non-smokers.
So the risk ratio changes based on the illness?
Oh, you bet. See, this is what epidemiologists calculate. So if we looked at, I'm just making this up, I'm making this number up. If we looked at relative risk ratio of developing breast cancer in smokers over non-smokers, you would see that relative risk ratio being much lower for breast cancer than it is for lung cancer, as an example. But does it make sense that you're looking at times the risk? But again, you've got a rate over a rate, and then that gives you that ratio. Okay, so let me go back to, okay. So we can, and keep in mind, you can look at relative risk. You could look at it as a morbidity statistic. So that lung cancer example was a morbidity. It was cases of getting lung cancer. You could also look at it as a mortality. It would be risk of death from a particular type of disease over a vulnerable population versus those who don't have that risk factor. So in that situation, I was talking about risk factor of smoking versus non-smoking. Okay. So a rate over a rate gives us a ratio. This tells us times the risk. And now let's play with the math a little bit here. Okay. So numerator is whatever's being assessed, whatever risk, or we could be looking at a protective factor. The denominator is the population who's vulnerable. So again, if we were looking at ovarian cancer, we would not have dudes in the denominator, okay? Because only women have ovaries, so only women are able to possibly get ovarian cancer. Provides us with the relative probability or the times the risk. So this is really valuable information that epidemiologists are able to calculate in a relative risk ratio. So now let's practice here. A relative risk ratio, that's accurate, the lung cancer one and the smoking, that's huge, huge in terms of how robust that number is. Epidemiologists, they probably open champagne when they're running new data and they get a 1.2. They're excited about 1.2. They've found something, okay? So when I talk about 10 being huge, I'm just using that 1.2 as an example. What if they got a relative risk ratio of 1? Somebody answer me, what do we have there?
That means someone who's not at risk has just as much risk as someone who's at risk?
Yeah. Or
Okay,
said,
that sounded really weird.
or said simply, nothing's happening there, right? It's the same. Yeah. Don't confuse this with correlation, y'all. You psych majors, don't confuse this with correlation because, yeah, a 1.0 means nothing's going on here. Yeah. So it could be like, I don't know, hair color and your risk for breast cancer. Nothing's happening there. Yeah. All right. What do we have when we have 0.7? So we've got less than 1. Anybody?
Those at risk have less of a chance of getting whatever than those not at risk?
Yeah. Now we're studying a protective factor. So let's say we're looking at fruit and vegetable consumption and risk of cancer. And we find that people who consume a lot of fruits and vegetables have less likelihood of getting any kind of cancer than people who have very low levels of consumption of fruits and vegetables. Yeah. So again, just like when we talked about in health behavior, increasing healthy behaviors, decreasing unhealthy, in epidemiology, you're studying risk, but you're also studying protective factors. Okay. Questions here? Okay, I want to give you a local example. So this is me and JP Jameson and Dr. Amy Page over in sociology. And we were interested in rural teenagers who were victims of interpersonal violence. So part of my research track is body image, obesity, fat talk, that kind of stuff. And part of my research track is interpersonal violence. And I've combined those two in different studies. And we were curious if local teens and local high schools, and this was YRBS data, Youth Risk Behavior Surveillance Survey, which is a survey that comes out of the Center for Disease Control that our local health departments use. And they give these surveys to high schoolers. Many of you probably took the YRBS at some point in time in middle school or high school. And we were interested in the 2 high schools in rural counties, Ashe County and Allegheny County. And we were interested in comparing those with a history of dating violence, which was they had been a victim of physical dating violence where somebody had hit, punch, slapped them in a dating relationship. And we were also interested in these teenagers who had been raped, both the guys and the gals who had a rape history. And what we were interested in was we asked the individuals if they'd been a victim of physical dating violence, if they had been a victim of rape, and then the both right over here is if they reported they'd been both a victim of dating violence and they had been raped in their history. And we took all of these other risk factors, and what I've done here in this table is I've stacked these up with the highest relative risks first, and then they go down. Now, these are the females. So these are these local high school rural females. And what we found is that those who'd been victims of both types of interpersonal violence were almost 9 times higher the risk of substance abuse compared to those who had 0 of those 2 types of violence. Does that make sense in the relative risk ratio? Okay. And one of the things you're seeing here for these females is that there was a lot of different risk factors associated with a violence history. So we've got depression, almost 6 times higher, risky number of sexual partners, which was actually defined as 6 or more sexual partners within 3 months. And I remember I had to draw the line at how many sexual partners in 3 months one day to be able to categorize this data. And I remember when I was doing this, I woke up that morning feeling like very open-minded, psychologically flexible. And as I was working on this data throughout the day, it occurred to me, and I was just I was feeling judgmental and I was feeling conservative. And I was like, how does a high schooler find 6 or more sexual partners in 3 months? Because that just seemed high to me. And then after feeling judgy, I had a chill fall over me, because it was rumored in one of these high schools in particular that there were foster parents prostituting their foster children. Yeah. And then it was the kind of like, okay, yeah, maybe some of these kids just get around a lot and have a lot of sex with a lot of sexual partners, but maybe some of these kids are reporting what's happening to them, that they're getting sold. They're getting sold out from foster parents. Then the third thing that occurred to me that day was like, well, good, at least those students were in school that day. At least they were in school. They were eating a hot lunch, and at least they were at school that day. Okay. So enough of that. And we can keep going down. Suicidal ideation, having a suicidal plan, 2.4 times more likely to have made a suicide attempt that required medical attention if they had been a victim of physical dating violence. And then I want to go down here. I want to talk about the grades thing. And I have a lot of passion for studying interpersonal violence, because unfortunately, when I was looking at this data, I'm going to show you the guide data here in a minute. I had this sadness kind of come over me of like, oh my gosh, look at what has happened to these poor rural teenagers. If they're a victim of violence, a lot of times it changes their whole life trajectory. So let's talk about the lower grades. These gals who were not a victim of violence had on average an A GPA. These gals that had been a victim of either the physical dating violence or had been raped had on average a C GPA. And a GPA and a C GPA in a rural high school is going to definitely mean the difference of whether or not these gals were capable of going to community college or capable of getting into a 4-year college if they desired to go to college. You got it? Okay. Take that. I told you about Dr. Jody Palaha yesterday, who works in peds and at ETSU. She has found the #1 reason in rural areas when a parent brings a child to a pediatrician, concerned that their child has some type of special needs diagnosis. So we could be talking autism spectrum disorder, we could be talking ADHD, we could be talking learning disability, we could be talking conduct disorder, we could be talking depression, all that kind of stuff. The #1 predictor that a kid gets in front of a pediatrician and a parent says, I am worried that something is going on with my kid, is mom, not dad. Mom has a college education. Got it? And doesn't that make some sense? Because a college education is going to give both moms and dads, but the best predictor was mom, some indication of this is normal childhood development versus there's something unusual about my kid, and I'm going to go to the pediatrician and ask if the pediatrician can help me with this. Got it? So when I think about these people do you see what I'm talking about? Potentially changing the trajectory of somebody's lives. And that is very sad to me. In clinical work, I've worked with a lot of people, both men and women, who've been victims of trauma. And it takes really hard work in therapy to overcome PTSD, to overcome trauma, and take a life trajectory going that way and move it back in a healthier way. Okay, so I've seen this both from the clinical standpoint and from the scientific standpoint. Okay, so I know you want to see the data on the guys. There weren't as many associations here for the guys, but up here, guys who'd been a victim of both were a lot more likely to have risky number of sexual partners. Same kind of thing, risky sex without a condom, if they had been a victim of both. The depression rates were pretty high if they'd been victims of rape. Suicidal plan, pretty high, et cetera, et cetera. Okay, so what we're seeing in these rural teenagers is that being victims of these two types of interpersonal violence is associated with a lot of other risk associations and risk behaviors.
So I had a question on the last slide.
Okay.
With the lower grades, both of the relative risk was 1.2. So I was wondering why you didn't put the physical abuse and the rape together if they were both the same value.
The both actually didn't predict a relative risk ratio. It was equal. It was 1.0 if they had been a victim of both.
Okay. Oh, I see the difference. Okay. All right.
Yeah. Yeah. And keep in mind, we've done other research. There's all kinds of we've looked at more for like steroid abuse. We've looked at cyberbullying. We've looked at school bullying. So other forms of interpersonal violence. But in this particular study, we were just looking at the dating violence and the rape. Yeah. Okay. In another study that we did, and this one was with, some of you probably had Dr. Mary Ballard for your classes, and then we've got JP Jameson and me again. And in this particular study, we were interested in if being LGBTQ in a rural area, my hunch was, and the data confirmed that would be really hard to be in a rural area with a lot of fundamentalist Baptist churches with pretty conservative politics, okay, as opposed to saying being LGBTQ in a more urban area where people had more liberal values and more resources and that type of thing. And so what we studied here, what we found was the LGBTQ versus the students that identified as heterosexual, cisgender, had 5 times the suicide risk. They had 1.25 times the risk of being bullied, about twice the risk of school violence, having somebody assault them at school, 1.5 times the risk of using drugs, and 1.26 higher risk of engaging in unprotected sexual behavior. Okay, meaning it's tough. It's tougher on these LGBTQ kids in these rural areas than kids that identify as straight and cisgender. Questions there? Get a flavor for what the relative risk tells you? I show you these 2 local studies just to kind of give you a flavor for this is a way we would use this data. Yeah. Okay. Another statistic that's commonly used in epidemiology, attributable risk. So this would be the percentage of disease if we're talking morbidity. It would be death if we're talking mortality that is attributed to a particular risk factor. And so as an example, let me take you down here. Let's take a look at the lung cancer, because then I think this will hit home. The attributable risk of lung cancer directly attributed to cigarette smoking is 90%. 90% of the cases of people that arrive at lung cancer have gotten there because they were smokers. Another 9% of lung cancer is attributable to secondhand smoking. Okay, so being around people that smoke and breathing in their smoke. And then 1% would be other causes. So that might be like if you were a ship worker and you were exposed to asbestos in the shipyard, or my grandfather was a coal miner in West Virginia and he ended up dying. He got black lung, and then he got lung cancer, and then he had bone cancer, all attributed to breathing in coal dust for all of his working career. Would be other. That would be an example. And as you see here, you add these 3 up and you get 100%. So you can picture this in a Venn diagram as an example, or a pie chart. And this sort of tells you, whoa, smoking cigarettes is really dangerous, and whoa, being around other people's cigarette smoke is really dangerous. Questions? Okay. Okay. Now, I want to talk about determining causality through epidemiology. And I first want to tell you about what happened with Congress and the tobacco industry years ago when you all were children. I know you've had drilled in your head, correlation does not mean causality, right? Okay. And this is my pet peeve, and my honor students know this is my pet peeve. I hate it when people use the word correlation to mean any association, because a correlation is a statistic, okay? The real word when you're talking about associations is associations. It's not they're correlated, because unless you've run that statistic, that row, that correlation, you shouldn't be using that word. Okay. But I know you've had drilled in your head, correlation does not mean causality. Now let me tell you what happened in the tobacco industry, again, back when you were little kids. So Congress was worried that cigarettes were creating harm, and they called the CEOs of the tobacco industry to Congress to testify in hearings. And these tobacco CEOs, they flew in their private jets to Washington, D.C., and they testified. They were asked several questions, and basically what happened, the tobacco industry, they lied, and they lied. Number one, they were asked, is there scientific evidence that using tobacco products like smoking cigarettes causes harm? And they were like, oh no, we do not have the true scientific experiment to say causally that smoking causes disease or that smoking causes premature death. We do not have the true scientific experiment. Then they were asked, is nicotine addictive? And they're like, oh no, it's natural. It comes from a plant. It's natural. It's not addictive. Meanwhile, they had chemists back in their labs deliberately manipulating the nicotine to make it more addictive. So if you use their brand, you got hooked on their brand. Third thing they asked them, are you marketing to children and teenagers? Oh no, we would never market to children and teenagers, but when you turn 18, if you would like the pleasure of enjoying cigarettes when you are 18, you can legally buy cigarettes, and we are only marketing to adults. We are not marketing to teenagers. Meanwhile, back in their labs, they had marketing professionals running focus groups on kids and teenagers, paying attention to what teens paid attention to in an advertisement. And one of the things they learned out of those focus groups, as an example, children and teens pay more attention to an advertisement that has a animated character, a cartoon character on it, than children and teens pay attention to an ad that has a picture of human beings on it. And guess who watches most cartoons? Children. Got it? Yeah. That's how Joe Camel was born. That's why there's, have you ever wondered, what does a camel have to do with smoking cigarettes? He's a cartoon. And it caught the eyes of the children and the teenagers. Okay, so the tobacco industry lied. And we'll talk more about that when we get to the smoking lecture, of what eventually happened to that. But I want us to think about the true scientific experiment here. You take a bunch of beautiful young children, you got thousands of beautiful young children, you randomly assign them. 1/3 of them are absolutely not permitted to smoke at all in their childhood or their teen years. 1/3 of them, you randomly assign them and you have them start smoking, I don't know, a pack a day by their teen years. Another 1/3, you randomly assign them and you have them smoking 2 packs of cigarettes a day as teenagers. You track all of these teenagers into adulthood. You wait for some of them to get sick. You do the math. You do the comparisons. You wait for them to die. You do the mathematical comparisons on the death rates. And then you have the true scientific experiment, and you know, does cigarette smoking cause harm and cause death? Why can't we do that experiment?
I would say it's very impractical. I mean, to follow someone around their whole life.
Yeah. Well, it's not only just, it's not only just impractical, right? It's
I feel it's also very cost ineffective for longitudinal studies.
Yeah. Well, it's not very cost effective. And does anybody want to take a moral stance?
Unethical.
Yeah, it's unethical. Yeah, it's absolutely unethical. And somewhere in here, it's unethical because we kind of know it's too dangerous to randomly assign kids to pick up this habit, right? Now, keep in mind, it is ethical, and we do have animal research on this. You can take animals as long as you got IACOC approval and you do everything ethically with the animals. And we do have animal models where you've had primates smoke, primates not smoke, rats smoke, rats not smoke. They don't hold the cigarette, they get a hot box. But anyways, we've got the animal model research that shows, yeah, causally, having the hot box smoke pumped in and having double the dose, 2 packs a day versus 1 pack a day, yeah, it causes cancer and lung disease, and it causes premature death. Okay, so now what I want to do is talk about how epidemiologists take naturalistic research with human beings, and they approach very confidently causality. So let's take a look at this. So again, we're not doing the scientific method experiment on human beings, but we're taking a look at all the body of research that's out there on human beings, and we're looking at these different criteria. Number one, causality, consistency. And we do consistency across studies with meta-analyses. So as long as the studies have been done well and they meet inclusion criteria, every subject in a meta-analysis is a separate study, an independent separate study. Every subject is one study. So you've got a study of studies here. And meta-analyses and comprehensive review articles give us this consistency. And we see this when it comes to cigarette smoking and development of cancers, heart disease, stroke, premature death. We've got it. We've got consistency across the studies. Number two, how strong is the relationship? How strong is the association? This is our relative risk. So like I said, relative risk of smoking and lung cancer, 10.0, huge. Relative risk of breast cancer, lower. Relative risk of cardiovascular disease, lower. But we look at how strong that association is. Number three, specificity of the relationship. This is how specific is that risk factor to that disease. When it comes to lung cancer, remember the attributable risk was 90% smokers, 9% secondhand smoke. That's great specificity. We have poorer specificity when we start looking at cardiovascular disease. So smoking does contribute to cardiovascular disease, but there's so many other ways people can arrive at cardiovascular disease: stress, genetics, diet, lack of exercise, etc., etc. So many other ways people can arrive at cardiovascular disease without necessarily being a smoker. So less specificity there. The more the specificity, the closer we are to causality. Okay, don't worry about the webs of causation. Number four, this is a real simple one. Temporal relationship, temporal meaning time. You have to have the risk factor there first before the disease develops. If it's going to be causal, it's got to be there first. It can't be like a sign or a symptom that shows up after the disease has developed. Okay. You usually get smoking before you get cancers. It's not that you get cancers and then people take up smoking. Make sense? Yeah. Number five, the coherence.
Could you explain number four again? I wrote that it was time, but could you just explain it in a different way?
You've got to have the risk there first. If the risk causes the disease, you've got to have the risk there first to have time to cause the disease. Yeah. Okay. So number five is coherence, dose response. Sometimes we use a correlation to take a look at this. If it's a stair function though, as an example, a correlation is going to kind of wash out a stair function. So we've got other mathematical models that we use here. But with the cigarette smoking, we know this. So a 2-pack-a-day smoker is much more dangerous than a 1-pack-a-day smoker. 3-pack-a-day smoker, much more dangerous than a 2-pack-a-day smoker. We know this from this research, which is why if we are counseling a smoker who's willing to cut back on their cigarettes, by all means, help them cut back. Not everybody is willing to quit. If you can help them cut back, you've lowered their risk. Okay. Number six, biological plausibility. Does it make sense on a biological, maybe a chemistry, maybe a physics level, that being exposed to that risk factor could possibly cause that disease or lead to premature death from that disease? When I think about cigarette smoking, you've got carcinogens in the smoke, and you've got this sticky substance, this gluey sticky substance called tar that's naturally occurring in cigarettes. You take the carcinogens, the chemicals that mutate DNA, and you inhale it into your lungs, and it just gets, these carcinogens get glued in that sticky tar, glued to the healthy lung cells. It makes sense. If you've got a chemical that can mutate DNA and it's just glued there, it's going to mutate DNA of those lung cells and spin out cancerous malignant cells. Does that make sense? Lots of biological plausibility there. Yeah. Okay. Prevention trials. Prevention trials would be, and we've done this with the smokers as an example. So let's say we take a look at, we track, let's say average age 50, never smokers. And then we have a comparable group of anchored at age 50, quit smoking 10 years ago, a pack a day. And then we compare that to anchored at age 50, a group of former smokers that quit 20 years ago. And we take a look at their health risks. And because of that research, we know that the longer a person has been a former smoker, the more they start to approach and asymptote the never smokers in recuperated health, as long as they don't have some serious disease that's going to kill them. But this would be taking normal human subjects and just looking at those who had the risk factor but got rid of the risk factor, comparing that to people who never had the risk factor, and looking at their disease rates and looking at their mortality. That we have. So when we look at former smokers, that's why we know the longer it's been since they've quit smoking, the healthier they tend to be, or the more they look like non-smokers. Okay. So let me go back real quick. If we meet all 7 of these criteria, we are very, very confidently approaching the assumption of causality, even though we've not done the true scientific method experiment. Does that make sense?
Could you say that one more time?
So if we meet all 7 of these criteria, we are very confident. It's kind of like statistical significance when we do statistics. We are very confident that we have met the assumption of causality. So we haven't proven causality, that would be the scientific method, but we are very confident about the assumption of causality. And then keep in mind, I'm going to assume a lot of you in here have had statistics, and statistics are all about probabilities. So you never really prove anything or disprove anything, but you've got these different probabilities with your curves. Okay, so let's talk about the 3 major type of research designs. I'm going to stop share here, and I'm going to start with prospective, and I'm going to go over and do my whiteboard again. Prospective research. And let's start with the Framingham study as an example. Open whiteboard. Okay. Oh, I guess I got to erase. Clean up. Okay. Okay. Erase is pretty good. Okay. Prospective. So prospective is going to mean into the future. So let me give you an example of the Framingham study, which was one of the first studies that gave us an idea of what causes heart disease in people. Where's my draw? Okay. So I've got men, every 3rd man from Framingham, Massachusetts, and they start, this would be time 1. I'm on here. And then, I don't have coronavirus. I'm just choking. All right. And I measure things like how much exercise they get, and I take a look at their diet, and I measure their blood pressure, and I measure their heart rate. And then I track these men over time, and then I do those tests again, and I track them at time 2, and then time 3, time 4, time 5, time 6, all that kind of stuff. And I've got every 3rd man in Framingham, Massachusetts. And so I can assume I've got a representative sample of that population of middle to older age men in Framingham, Massachusetts. And I track them into the future, and I learn over time, you do the math and you do the statistics, that these men who exercise on a regular basis, follow a healthful diet, manage their stress well, are partnered in a long-term relationship, they have less heart disease, less stroke, are less likely to die prematurely Then the men who are sedentary, who eat a lot of fast food and a lot of meat and a lot of high-fat diet, the men who aren't partnered with a long-term relationship, the men who have a lot of stress, et cetera, et cetera. So you start tracking people prospectively into the future, and then you collect the statistical data, and then you make conclusions based on that data. The problem with prospective research is you've got to know from the get-go what stuff to track. So like, let's say we're tracking these guys and we're looking at their self-reported exercise, but it's not until time 3 that we've got an electrical impedance device where we can do body composition and know their muscle ratio to their fat ratio to their skeletal and their bone mass and all that kind of stuff. And at time 3, we start doing electrical impedance. And then we've got that data at time 3, time 4, time 5, time 6, but we don't have that data at time 1 and time 2. Got it? Okay, that's prospective. The second research design I want to talk about is retrospective. And let me clear. Oh, I can clear. I don't have to erase. Cool.
Oh, I had a question about the prospective research design. Is there like any pros to it at all?
You get some beautiful data. The pros to it is if you track people longitudinally, and a lot of times there's whole research teams or centers that do this, because even the researchers die. I mean, if you track these things long enough, everybody's going to die, kind of thing. So a lot of times it's a center or a grant-funded center that keeps doing this. You get lovely data. It's not causal data necessarily, right? But as long as you've got a nice representative sample, it's great research. Again, sometimes you just get new technology and new things to roll in and track that you might not have tracked forever. Okay. So if prospective takes us into the future, retrospective is going to take us back into the past. So I'm going to give you an Alzheimer's example. So let's say oh, that's an arrow, not a drawing instrument. Maybe let me just describe this to you. I'm going to describe it to you, but when we get into the experiment, we'll do that one. Okay, so I've got a group of elderly men who have Alzheimer's disease, and I make sure that the men recruited in my study, they all have wives that have been with them all of their adult lives. And then I find a comparable control group of men the same age, the same race, they're all matched in age and race and all that kind of stuff. A comparable control group of elderly men who do not have Alzheimer's disease, who are married to a wife who has been with them all of their adult life. So I've got my experimental group, those with Alzheimer's. I've got my comparable control group of men without Alzheimer's. And I'm going to give very detailed interviews to the wives. Now, why would I interview the wives about their history, their lifestyle history of these men, and not interview the men?
Well, because the women have seen it, so they'll probably remember it better than the men themselves. They're probably not as they don't pay attention to their behavior as much as probably their wives do.
Which is why women nag their men. I know, yeah. But some of it here, a big confound here, is the dudes with Alzheimer's are not going to have the same memory as the dudes without Alzheimer's, right? So you're doing the wives, assuming that they are healthy and they can remember. You're interviewing them. And again, so you're going back in time. And let's say what you find out is that the wives of the healthy men say they got a lot more exercise in their lifetime than the wives of the men with Alzheimer's, saying that they got very little exercise in their lifetime. Got it? Okay.
Which one were the control groups? Was that the one with the Alzheimer's or the non-Alzheimer's?
The non. And you keep in mind, you got to match. You gotta make it as comparable a control. It wouldn't be fair to have middle-aged men in the control group and elderly men with Alzheimer's in the experimental group. You got to match them: race, age, socioeconomic status, all that kind of stuff. And again, epidemiologists know how to control for that. All right, true scientific experiment. Let me get back to drawing. See if this will. All right. First of all, you've got a whole population of whoever you're studying enrolled in your study. They've signed an informed consent. Your study has IRB approval, all of that. You're going to take this population and you're going to randomly assign it. And in my particular study here, I'm going to have group 1, group 2, in group 3. And just for the sake of ease here, I'm going to make group 1 my control group. And I'm going to make this a drug study, but this could be a study of psychotherapies. It could be a study of a lot of different types of treatment. And I'm going to make group 1, let's just say whatever my drug is, 1 milligram. And I'm going to make group 3 of whatever my drug is, 2 milligrams. Now, for people enrolled in my study, they're going to be randomly assigned, but there's going to be this thing called double blind. The first blind is that the subjects in my study, they're going to get randomly assigned to group 1, 2, or 3, but they're not going to know which group they're in. All they know is they're going to be handed over by a research assistant a bottle of pills, and they are supposed to take that pill, 1 pill every morning, come back to see the research assistants 1 month from now, bring their pill bottle. Got it? So who's the other person who's blind? So the participants are blinded, but who else is blind?
The researchers?
You got it. Now, somebody, principal investigator at the top, is got to know who's getting group 1, group 2, group 3. Okay? And a lot of times the way that is done is those pills may have a number on it, but nobody knows what the number means. Or it may have a letter on it. Nobody knows what the letter means. So it's actually the research assistant. The research assistant who gives you the consent form, who's nice and kind to you, who hands you the bottle of pills, that person too is blind. Because what you don't want is a research assistant going, oh, you can take these pills. I don't know, you're in the control group. I don't know if they're going to help you much, but go ahead and take them. Or, oh, you got lucky. Here's your pills. Right? You can't have that person knowing. They've got to be totally blind. But again, the researchers at the top have this stuff coded in a way they've got to know who's getting what. Now, keep in mind, the pill has to look exactly the same for everybody. So if this is a square, that'd be silly. That would hurt. A round, let's make it round so it swallows. A round pink pill, this is the same size round pink pill. This is the same size round pink pill. But there might be a letter or some number that is coding them so that at least the research assistants know how to, the researchers up top know how to fill the bottles. Okay, now there's this other effect that people get, which is really interesting here. People here who comply. This is comply. This is non-comply, the nons. And the way that they do that, let's say you're in a pill study and you're supposed to take 1 pill every morning, 30 days, and then you go back to the research assistant and you take your pill bottle. That pill bottle might have a little electronic cap on it. Assuming the research assistant is able to read that, they'll take the cap, put it in, and it'll electronically read it. If that pill bottle was opened 30 times in the last month, the assumption is you took your pill every day as you should. Got it? Let's say you're the research assistant, you put the pill cap in to read it in the computer, and this particular person in the research study opened that pill bottle 5 times that last month. You want to be able to, if that's 5 times and this is 30, you want to statistically, as the scientists in this study, be able to remove anybody who did not adhere or did not comply with your research protocol. If anybody's got 5 or less, let's say, or actually you could even set the bar at 28 or less, you've given yourself to remove them from your research study. Does that make sense? Because how do you know if a pill works if they're not taking it? But what's fascinating, let's say this drug works. Let's say whatever it is and whatever it's for, it works. And we find the 2 milligram, those people get so much better than the 1 milligram. They get so much better than the people over in the control group who are getting the placebo. If it works, you're going to see that effect. And you always have to show that the effect is above, statistically above and beyond placebo, because we always get a placebo effect in this research. But here, my friends, is the most fascinating piece of this. The people getting the placebo who don't know what they're getting, who comply, and they take the drug like they're supposed to on a regular basis, they get so much better than the people randomly assigned to the placebo group who don't comply who do not take the medication like they're supposed to. What is that?
Placebo effect.
It's placebo times placebo. You got it. But the important psychological placebo effect is the people who take the medication on a daily basis, they've got hope. Remember the new medicine and the hope? They've got hope. They've got belief. They've like, this could help me. I'm going to take it every single day exactly the way they told me to take it. These over here in the non-comply, they're going to be like, you know, I don't think this is going to be very helpful. How can this little pink pill help with this horrible disease I have? So they don't take it on a regular basis. They don't have the belief. They don't have the hope. They're not going to get the full placebo effect. Does that make sense? So true scientific experiment. Now, this could be a psychotherapy, but then keep in mind, if it were a psychotherapy, you're not going to be blinded. You're not going to have like a placebo pill. If you've got a therapist who's just only talking about emotions with you, you're going to know that therapist is only talking about emotions with you. If you are with a therapist who's practicing acceptance and commitment therapy, you're going to know that they're talking about your values. They're going to be talking about your true north. You know, you may not know that this is acceptance and commitment therapy, but in a placebo, when you're a participant, not a placebo, when you're a participant in a psychotherapy trial, you know what you're getting. You might not know the names of what it is, but you can't be totally blinded to it. Okay, couple of more factors. I know we're closing in on time, but I want to go ahead and get through this today so we can just focus on stress tomorrow. Some other variables that epidemiologists look at, person factors, would be things like we regularly look at sex, male, female. Epidemiologists started looking at non-binary, trans, that type of thing. We look at race as a common demographic factor. We look at socioeconomic status, how much money does your household income have? What level of education do you have? Those would be different person or demographic factors. In this particular study that I told you that we looked at interpersonal violence in these rural high schools, we divided the participants into white and non-white. We had racial data, but the reason why when we got this published, we did not report Asian, African American, Pacific Islander, because those kids could be identified. You know, the one Asian male that had been raped, he's the only Asian male in that high school. Oh, that's the dude who got raped. You know, yeah, we would not want to make it that granular. So we divided it into white, non-white. And just as an example, when we look at females who've been victims of interpersonal violence, being white is a risk factor at 10%, being non-white, double that. Guys, physical dating violence, 11%, guys, non-white, double that. Being raped, females, white. Being non-white, almost double that. Guys, being raped, about 4%. Being non-white. What does this tell you about being non-white in a rural high school, folks?
You're more likely to get abused.
Yeah. You're at much higher risk of interpersonal violence. Yeah. Place factors. My partner, JP, he does a lot of research, and he likes zip code research, and he gets all excited when he gets zip code data related to other kinds of things. But I'll give you a quick example of this. Okay, so Watauga County, Blowing Rock zip code, age-wise compared to Boone, what do you think? Higher average age, Blowing Rock? That's where all the rich people have their second homes. Higher age in Blowing Rock than in Boone. Blowing Rock, higher family household income than Boone? You bet. I got to tell you this one story. Cheryl Fox, who is on our faculty, she was a school psychologist in a previous life before she became an adjunct for us. And as a school psychologist, she was out in Bethel. Bethel zip code, very, very different than Boone zip code. Very, very different than Blowing Rock zip code. Cheryl's out there about to test this little boy out in Bethel. And she's just building rapport with him as she's setting up her test kit. And the little boy asked her, he's like, where do you live? And she says, well, I live in Boone. And the little boy's face lit up and he went, oh, I've heard there's a McDonald's there. Kid had never been to the big city. He had never been to Boone. That's how remote rural gets in the Bethel zip code, if that gives you an idea. Okay, so that would be an example of place factors. Time factors would be those trends where you're kind of tracking stuff over time. And I can go back to that to see if anybody has any questions here.
I'm still confused by place factors.
Place would be like the zip code of your home.
Uh-huh.
Does that make sense? Or it could be, for as an example, Watauga County is not considered to be rural because of the educational level of people in Watauga County and because of the population density in Watauga County. So when I gave you this data from these two rural high schools, I'm talking Ashe High School and Allegheny High School. Those counties are considered by, and there's government classifications, they are considered to be rural. So you look at population density, you look at how far those counties are from a more urban district like Greensboro, Winston-Salem, or Charlotte. And then you also look at one way of determining socioeconomic status in the high school is what percentage of the kids are on free breakfast and free lunch. And the higher the percentage of kids on free breakfast, free lunch, the more poverty you've got in that high school, the lower the socioeconomic status. Does that make some sense? And then thinking about, just even think about the high school. My kids went through Watauga High School, professors' sons. Watauga High School has a lot more kids coming from families with higher education than kids in Allegheny and Ashe County, where the majority of those kids came from families with parents with a high school education. So socioeconomic status is a function of education level and income. Other questions? Epidemiologists during this pandemic have been very valuable to us. They have been able to help us understand personal protective equipment. They have helped us understand a lot of that data that I presented to you in that intro lecture, how far droplets from a cough travel and how fast, how far sneezes travel and how fast. There are people been doing simulations to be able to determine that information. Epidemiologists have known about social distancing, personal protective equipment. They've been tracking these other epidemics. They've been tracking the viruses and the bats, that type of thing. They have, thank goodness, those scientists have been out there collecting this data over time, because even though our country maybe didn't react and act quickly as we should have relative to some other countries, at least we've got this science feeding us this information. Okay. Again, when I was in graduate school, we were not in a pandemic. We had an AIDS epidemic. We had HIV and AIDS. And those epidemiologists were very quickly able to help us realize that by kissing somebody who was HIV positive, it was very, very challenging to actually contract the disease definitely not with a hug. Very challenging to contract HIV just by kissing somebody. But if you were sharing bodily fluids, having anal sex, anal penis sex, or penis to vaginal sex, very easy to share bodily fluids. And even back in the day, we learned as a woman, if you were having heterosexual intercourse with somebody who was infected without a condom, without protective sex, much easier for a woman to receive HIV than for a woman heterosexually to give a dude HIV. That's how we learned anal sex was the most hazardous, because if you think about the function of the rectum and the lower part of the colon, it is to absorb water, which nicely keeps us from pooping like a horse or a cow anywhere, anytime, even as they're roaming around. Very absorbent. If there was HIV in seminal fluid, it very easily would get absorbed into the bloodstream from the lower digestive tract, as an example. HIV actually very difficult to transmit. Coronavirus, very easy to transmit from finger touches of virus to face, or by inhaling droplets of somebody who's infected. God bless the epidemiologists.
Okay. I also had a question about the exam, like now that we're getting pretty close to it, like because it's on Thursday.
Yeah.
What are like the big take homes maybe that we should be like really focusing on like during our studying? Like, I mean, obviously everything that we've learned thus far is very important, but like,
when it comes to numbers, big pictures. So I do want you to know like the first 3 leading causes of death before coronavirus, but I don't expect you to know the percentages or the raw numbers. And then I want you to know, now we have more deaths on a daily basis from people infected with coronavirus than any of the other leading causes of death, right? So a little more kind of big picture types of things.
Okay.
If like on, let's go back, there's one of our local studies. This study here, I would not ask you, what did Ballard, Jameson, Martz, who published in 2017 in orthopsychiatry, find? What I would do is say, Ballard, Jameson, Martz studied LGBT kids in rural areas versus kids who did not identify as LGBTQ. What were some of the risk factors that we found the LGBTQ kid had relative to the non-LGBTQ kids? So it'd be a little bit more big picture. Some of there is just a certain amount of memorization. Now you'll have open book, open note, but you won't have much time to look up stuff. So I'd much rather you commit stuff to memory. There will be some test items that are more like pull stuff together and apply it.
Okay.
Yeah, so like if across these different studies, if I asked you in rural teenagers in the surrounding rural counties, if they've been victims of interpersonal violence, what are some of the other risk factors they have? And so you could, psychological disorders, suicide, risky sexual behavior. It's harder to be an LGBTQ kid.
Okay.
50 multiple choice items. Y'all will have 40 minutes. I think we can get through all the stress and coping lecture tomorrow. If we don't, I might need to own a little bit of time at 3 o'clock on Thursday and then open the exam for you. But I think we'll get through the stress and coping lecture tomorrow. I don't think that'll be a problem. And then do you want me to open a review session, like just a Zoom session where you can come into my room on Thursday afternoon before 3 o'clock for questions?
Sure.
Okay, I can post that. I'll post that. And so y'all could come and ask me questions just kind of as a, study review type of thing before you take the exam.
Cool.
What about textbook questions or any definitions from the textbook?
I am not using the textbooks this summer at all.
Oh,
I used to have like a handful of textbook questions on the exam. I pulled them all out of there.
Sweet.
Yeah.
Good to know. Thank you.
Yeah. I do want you reading the Walsh article, watching the Netflix Explained, reading that How to Avoid Coronavirus article. So anything that's in lecture and any of the reading or watching materials, that's fair game. Other questions? All right. We finished behavior change and we finished epidemiology. I will see you all tomorrow where we will cover stress. Y'all have a great evening. See ya.